Chairman, we are now live.
Thank you, Nikki. Welcome everybody to this virtual meeting of the External Services Select Committee at London Borough of Hillingdon. This virtual meeting is also being broadcast simultaneously on the Council's YouTube channel, Hillingdon London, so welcome to anybody who's viewing as well. The purpose of this committee is to monitor those bodies outside the Council that provide public services to Hillingdon residents. We scrutinise performance of these bodies and undertake in-depth reviews and witness sessions on topics, submitting any findings to the decision-making cabinet. My name is Councillor Nick Denys and I'm chairman of this committee. Just before we start, I'm going to mention some online housekeeping. Please ensure that your mobile phones are on silent and any home listening devices such as Alexa are turned off. Please keep your microphone muted and when not speaking, and then unmute to speak. As chairman, I will call on those to speak during the meeting, and if you'd like to speak, use the hand function at the top of your screen and I will note down that you want to speak. In terms of technical meeting control, any councillor who leaves the meeting partway through for a period of time lost connection will be able to rejoin, and I will continue the meeting unless we're not quorate, which is 5 councillors, and Nikki will let me know if at any point we're not quorate. Okay, tonight's meeting is both interesting and important. I obviously say that for every meeting. We will start off by looking at plans to improve cancer services in our area. Then we'll hear about what is hoped to be achieved by the Hillingdon Hospital redevelopment. And finally, we will look at Hillingdon Hospital Trust's performance over the last year and hear about what improvements have been made since the last CQC inspection, all things that I know our local residents are very, very interested in. Before we go through the agenda, I would like to do a roll call of the councillors and others present to confirm attendance. Please, can you indicate you're present when I say your name? Okay, first of all, apologies for the background noise, it's just my children are just finishing dinner, so obviously making their way upstairs. Right, so first of all, Councillor Devi Radia.
Hello, Chairman. Yes, I'm present.
Excellent. Councillor Simon Arnold.
Good evening, Chairman. I'm present.
Excellent. Councillor Ray Graham.
Good evening, Chairman. Yes, present. Thank you.
Good evening. Councillor Vanessa Hernahy.
Evening, Chairman. I'm present.
Good evening, Vanessa. Councillor Stuart Mavers. Stuart, I have seen you, but I think your mic might be on mute.
Good evening, I'm present.
Excellent. Good evening, Stuart.
My buttons aren't working.
Yeah, no, that's something that often happens, isn't it, in these things? Right. Councillor Ali Milani. Okay. Councillor June Nelson.
Good evening, Chairman. I'm present, and I'll give Ali's apologies as well.
Thank you, June. Right, next up, I'll introduce those who are here to talk about the cancer services. And if I get anybody's names wrong, apologies. It's due to my bad reading. Ruth Derrett from
Yes,
NHS.
thank you. Good evening, everybody.
Good evening, Ruth. Jessamy Kinghorn.
Yes, thank you. Hello.
Hello, Jessamy. Susan Sinclair.
Yes, hello.
Hi, Susan. Leslie Watts. Okay. Sarah Bellman.
Hello, yes, I'm here.
Hi, Sarah. Now I'd like to introduce those who are here to talk, or here on behalf anyway, of Hillingdon Hospital. Patricia Wright.
Yes, hi, I'm here.
Hi, Patricia. Jason Sees.
Hello.
Hi, Jason. Tina Benson.
Apologies from Tina, she's on leave.
That's okay. David, is it Meikle?
It is Meikle, yes, thank
Fantastic.
you. Good evening. Good evening.
I never normally get that right when I don't know, so that's brilliant. That's already a great start to the meeting. Hi, David.
Hi.
Sir Neil McKay.
Hi, I'm here.
Hi, Neil. Rachel Benton.
Hello, yes, I'm here.
Hi, Rachel. Tahir Ahmed.
Hello, good evening. I'm here.
Good evening. Dr. Abbas Kaku.
Present.
Brilliant. Cassie Hill.
Hello, yes, good evening.
Good evening. We're also joined today by Caroline Morrison from Hillingdon Health and Care Partners. Hello, Caroline.
Good evening, everyone.
Good evening. And finally, and definitely not least, our officers from Hillingdon Council. Tony Zanneman, are you here, Tony? Not at the moment, that's okay. Gary Collier? Okay. And finally, and most importantly, Nikki O'Halloran, our Democratic Services Manager. Hi, Nikki.
I'm here, Chairman.
Brilliant, fantastic. Okay, excellent. Now we've gone through all of that. Oh yes, is there anybody I've forgotten to mention? Brilliant, fantastic. Just a reminder, anyone who wants to speak, please use their hand up functions and I'll call you. Also, if it's the first time you're speaking, can you just say what your role is? I didn't go through it on the introductions because I thought that would take a long time. So just when the first time you speak, just explain who you are in case people haven't met you before. Right, we're going to move on to the agenda. Nikki, do we have any apologies for absence?
Chairman, the only apology is from Councillor Milani.
Thank you. Does anyone have any declarations of interest in matters before this meeting? If there is silence, I will take it as a no. Brilliant. Okay, all items are public items, so it's being recorded and broadcast on the YouTube, Hillingdon YouTube account. Right, agenda item 5. So our first substantive item, the Mount Vernon Centre.
Chairman, sorry, can we do agenda item 4 first, please?
Oh yes, the minutes, of course. Sorry, minutes from the last meeting. If anybody has any amendments, please mention them now. Brilliant. The minutes are agreed. Okay, now we move on to the Mount Vernon Cancer Centre review. Who will be starting this presentation?
I will, Nick, if that's all right.
Yeah, go for it.
Would you like me to share my screen, Nikki? Is that best? Thank you.
If you could, that'd be great. Thank you, Jessie.
So I have a few slides just to guide us through, if that's okay, Chair, and then we can take questions. So thank you ever so much for having us back. It's very much appreciated. We've been a few times now, I think, to the committee. So what I'm planning on doing is really just running through where we've got to with the programme at the moment. I'll just cover a tiny little bit of how we've got to where we are, but I do know that the committee's had previous updates, so I won't dwell on that too much because I know you've got other things as well to fit on the agenda this evening. So really just to say we have continued to work on plans for Mount Vernon following that independent clinical review that you will recall that took place in the summer of 2019 now, which made some short, medium and long-term recommendations. And we've previously updated you that the short-term recommendations have all been put into place, and really the focus has been on the more medium and the long term, so the future for the cancer services and for cancer services in for Hillingdon and for all the other areas that the cancer centre serves, and also around the management of those services. So I'll provide an update as to where we've got to. Just as a reminder, this is the area that Mount Vernon serves. So the red pin is the cancer centre itself, and you've got other hospitals. Hillingdon Hospital is this one down here. Watford Hospital is number 6, and the catchment area goes all the way up to Bedford, across to Aylesbury, and over to Hertford and places like that. So it's a really big area. The darker purple illustrates the more patients that come from that area. And you can see that just as a reminder on this graph, really, in terms of where patients are coming from Mount Vernon. Around 14% are from the Hillingdon CCG area, and that's the third largest CCG area that serves the hospital. And when we break that down into numbers for specific treatments, you can see that around 500 patients have chemotherapy at Mount Vernon from Hillingdon, that around 450 patients have radiotherapy, but there are also inpatients, there's PET-CT appointments, there's day case, there's a range of services that are provided at Mount Vernon. And hopefully you will remember some of the background in terms of why we need to make changes, and the fact that actually this has been a subject of discussion. We can find records going back for more than 40 years, and it's always been very, very difficult to work out what the answer is. largely because of the large geography that it serves, finding a solution that everyone can get behind and support, and also the challenge around funding the scale of improvements that are required. And as a result of indecision in the past, we've got to the stage now where we really do need to do something. And again, I'm not going to read everything on each of these slides, but these are some of the reasons why. It's not just about the buildings, it's also about the clinical limitations that are on the services because of the lack of acute services on the same site, because of changes in cancer care, advances in research, people living longer, and just cancer care has changed a lot over the last 30 years. There is a lot more in the future that is going to change as well, a lot more treatments coming online, and the cancer centre, the cancer facilities and services at the existing site and the way that the service is configured currently won't be able to respond to that in the future. And there are treatments that aren't available on the site now that actually you would expect a specialist cancer centre to be able to deliver. So we've been looking at the options, and we looked at a range of particularly the two options that were recommended by an independent clinical panel. And you'll recall these were experts that we brought in from another part of the country entirely, so with no vested interest. They came from the Clatterbridge Centre in Liverpool and the Christie in Manchester. And they recommended that we should either go for a full reprovision, moving the whole cancer centre onto an acute site, or reprovision with some sort of a day hospital type facility left on the existing site. As with any case, we've also looked at a do minimum option, which really wouldn't achieve the clinical improvements that are required. And we do need to think about if we can't deliver one of the preferred option, what that would mean for patients in the long run. If we can't if we can't move services onto an acute hospital site, what does that lack of acute facilities mean? And things like access to intensive care, for example. So we have already had to restrict the admissions criteria for inpatient care, and there are fewer inpatients now being treated at Mount Vernon, and they are being admitted directly to other hospitals. And that is better for them in terms of their care and their safety. What it's not so good for really is that the clinicians are frustrated that they are having to care for their patients remotely in other hospitals. But the number of emergency transfers out of Mount Vernon has reduced as a result of the change to the admissions criteria, which has been a good thing. And the review also recommended we looked at networked radiotherapy, particularly in the north of the patch. So less of an issue for people living in Hillingdon, but there are some extremely long journeys from places like Bedfordshire, Luton, Stevenage, Hertford. So just moving through in terms of how we've gone through this process over the last few months since the last autumn. We've been undertaking a lot of patient and public engagement. It's been challenging in the current climate. We've done a lot of online focus groups, as you can see there, really to explore the clinical case for change, to look at the option for moving everything onto an acute site or an ambulatory model, looking at different patient pathways, looking at estates options, and then moving forward and exploring what some of the preferred options might be. So we were doing surveys and other things as well, so it's not just online focus groups, and we are trying to keep changing and improving and developing the way that we are engaging with people. So in December, the programme board considered all of the views and the feedback that we'd got at that point, feedback from the staff and clinicians from the integrated care systems, including North West London. And North West London, and I know that Leslie and Susan and others are here tonight, are members of the programme board, along with their counterparts in Hertfordshire and West Essex, Bedford, Luton, Milton Keynes and other areas. And all of the views were sort of fed into a discussion that took place in December around what the clinical model should look like and what the estates options might be. And the clinical group had recommended the single site specialist centre on an acute site, so that full relocation model, in conjunction with improved local access to some services such as chemotherapy and radiotherapy. And that was consistent with the patient feedback. The patient feedback had very strongly been that we should keep the staff team together. We should provide a cancer centre that could do as much as possible. And actually, for patients from, in particular, the north of the patch, their concern was that if we had an ambulatory hub or a day hospital as well, the service would be split and stretched, but actually it wouldn't provide any improved access to them because both the options would still be a long journey time away. And their preference was that we had a single site specialist centre, but looked at whether there were things that we could do closer to home that would help them out. And one of the things, for example, that came up repeatedly was blood tests. We heard story after story of patients who had a 100-mile plus round trip for a blood test just because of the way that the system works. So the recommendation is that we look at what we can do more locally, but that we move towards a single site hospital. We had a lot of conversation about cancer outcomes and health inequalities. And we looked at some criteria around, some very basic key criteria around the different site options, and came to the conclusion that there was only one site that met those criteria in full, and that was the Watford Hospital site. And you can see here that that was based on the clinical facilities of the site. So does it have critical care? Does it have co-located services? But also some travel time analysis. And the same methodology was applied to all of the hospitals in the patch. You can see there all the way up from Bedford, and including hospitals in northwest London. And looking at what's the average travel time for drive times, what's the average public transport times, and what's what would the average increase be? And we'd set some criteria that there should be no more than a 5-minute increase in average travel times by car. There should be no more than a 5 percentage point increase in the proportion of patients with long journeys, and long journeys were described as 30 minutes or more by car. And for public transport, again, no more than a 5-minute decrease on the average public transport journey time. But also we felt it was important that those patients with the longest journeys, so those travelling more than 75 minutes, there should be no increase in the proportion of patients travelling for those lengthy journeys. And you can imagine with the size of the catchment that we cover, that was always going to be a tall order to find an existing hospital site that met all of those criteria. And it was just Watford that did, and you can see those results there. We also looked at the feedback that we got from patients. These are just the ones from the 5 hospitals that I suppose did best on the scoring criteria, with the exception of Harefield, that didn't meet the criteria. And this is just a summary of the kind of consensus view that we had from people. And generally speaking, Watford was considered to be a good option by most people, or at least the best compromise. So it often wasn't necessarily people's first choice, particularly, for example, if they had a local hospital that was close to them, but actually it was quite commonly the second choice, or people felt it was a reasonable choice to make. Whereas you had people from Hillingdon, for example, that did not like the idea of Luton, were happy with the idea, or happier with the idea of Watford. People from Luton did not like the idea of it moving further into London, and so on. So I'm just going to run through them where we've got to now with this. So moving on from that single site hospital, we've started to work with the clinical team and with the patients around what that might look like. So this is an illustration really that you'll recall that we were looking at the management of the centre being transferred from a local district general hospital, Eastern North Hart, that runs it now, to UCLH, which is a specialist cancer centre. So the idea would be that UCLH would run the Mount Vernon Cancer Centre at Watford, and it would be a standalone centre run by the UCLH, not by the West Herts team. And it would be on the Watford site, potentially with a physical link to the Watford building, but it would provide all of the inpatient and outpatient services that could currently be provided at the Mount Vernon Centre. It would have cancer imaging, it would have information support, But it would also have things like haematology services, which it can't provide at the moment. Haematology services at UCLH would be transferred back into Mount Vernon for the population that live closer to the hospital, so people from the east of England. And then a range of more local services. So we felt that if Mount Vernon was to be redeveloped at the Watford Hospital site, that we should take the opportunity to develop chemotherapy services for the Hillingdon population in Hillingdon. And so we're having some conversations with Hillingdon hospitals, and I know that colleagues are here tonight to look at developing a chemotherapy service at the Hillingdon Hospital site, which it isn't there at the moment. And that will benefit quite a substantial number of the patients that go to Mount Vernon for their treatment. We're also looking at some radiotherapy options. So in the north of the patch, a new radiotherapy service at either Luton or Stevenage, plus the additional option for patients living in northwest London, that instead of a radiotherapy service at Watford, there would be the opportunity to use radiotherapy services provided by Imperial College. Blood tests and swabs and things like that locally, as I've mentioned, and looking at how we can provide more integrated support services for people, information and support in their local areas rather than just at the main cancer centre. And we've had some really good sessions with patients on that recently. I'm going to whiz through these slides if that's okay, because I don't want to spend all the time talking, but we can leave them with you and have a look. So we've just got some comments that clinicians have made, some of the things that patients have made, just to illustrate what they'd like to see in a new cancer centre. You can see disabled access and access to outside space and infection control, safe buildings is all important. So we're developing the options now. We're working with patients and the public on a series of workshops to look at what those plans look like. We are exploring the feasibility of the Watford site option and the timescales of that. The West Herts hospitals have their own new hospital scheme. The two schemes aren't dependent on each other, but there could be some potential advantages of aligning timescales. And trying to bring the clinical teams together to talk about what benefits there could be around the patient pathways. That's been a little bit challenging because of COVID pressures. Chemotherapy at Hillingdon is something I'm sure that you'd be interested in. There is already chemotherapy provided at a lot of the hospitals on the patch, and so we're looking at what we can do around Hillingdon. We do have oncologists with integrated roles in Hillingdon, so we're looking at potential for a new chemotherapy unit with a number of chemotherapy chairs for patients to be treated in at the hospital. And we will build those into our business case. Networked radiotherapy, again, this is primarily for the north of the patch, so I won't dwell on it, but we are doing a lot of work to understand whether and where the right place to put a second radiotherapy unit would be to shorten some of those journey times that are in excess of 45 minutes each way. And of course, radiotherapy is a treatment that patients come to daily, but also looking at extending the radiotherapy provision at Hammersmith Hospital in particular for those patients for whom that would be a closer option. Care close at home I've mentioned, so I won't dwell on that, but we're happy to answer any questions on that, looking at opportunities to see what more we could do locally for people. And as you can see there, PICC lines, swabs and blood tests were the things that have come out mostly from patients. A patient workshop I held the other day were really keen to look at how we could use video conferencing more rather than telephone conferencing, and things just to make life a little bit easier in terms of their travelling for treatments. We're looking at outcomes again. I think I may have shown you this slide before, so I'm not going to dwell on that one. And the management of the services, as I've said, we're looking at UCLH becoming the provider. They are going through a period of due diligence at the moment, and they are expected to make a decision later this year, in which case we would start planning for the transfer of the management of the service for April next year. It's quite a tight timeline, but that's what we're working to at the moment. But I also want to reassure you that we are continuing to support the Trust in developing services on the site. So there is a new radiotherapy machine that will be operational this summer, replacing the existing machine. There has been some expansion of outpatient capacity. There have been some improvements to wards and to computer systems, because it's important that we don't just wait for a new cancer centre to be built, but that we continue to make sure that we're meeting patients' needs now. Patient and public engagement, again, we're doing a lot. We're continuing to do patient and public engagement. We have a number of work streams underway at the moment. I have a group tomorrow looking specifically at disabled access, which will be fascinating. And so we'll continue to keep that going. We have a website which has had quite a lot of visitors and a lot of interaction, and we plan to do more with that, but also trying to do more in the communities as well. We are expecting that we will be undertaking public consultation on these proposals, and the earliest date that will be now, we think, will be September, probably mid-September. So I think just really finally getting to the end, the other key issue that we need to flag up is capital funding, that we haven't identified yet, the money that we will need to undertake this. So this is all going to be very much subject not just to consultation, but also to identification of the funding. But we won't be going to consultation unless we know that that funding is in place. We're not going to mislead the public that we have a wonderful plan for a new cancer centre if we don't know how we're going to pay for it. So that's really important that that's resolved over the next couple of months. And good progress is being made on that at the moment. And there you can just see that the plan for the next few months, that we are working up the options at the moment. We're going to have an independent clinical review of those plans in a couple of months' time. And then we will be looking towards consultation for September. And we're beginning to scope with Hertfordshire Scrutiny Committee. And I know that Natalie at Hertfordshire Scrutiny Committee has been talking to Nikki about setting up a joint health overview and scrutiny committee to scrutinise the proposals and the consultation as we move forward. So that's all I wanted to say. Sorry, I've run through that very quickly, but I realise I've also been talking quite a lot, so I'm sure you'd much rather be asking questions.
That was great, and to be honest, a lot of my questions that I was thinking of, you saw the next slide, you answered them, so that shows it was a very good job. And obviously, compared to when you spoke to us last time, the plans have developed a lot more, which is really great. So I suppose one of the things that had concerned me, or was of an interest to me, was the sort of travelling times and the access for our residents, because obviously in reality, you know, we sit here, we're in Hillingdon, but borders don't really mean that much to people. What is important to people is practical access to services. And, you know, I mean, Watford General Hospital is only about 10-minute drive anyway from Mount Vernon. So, I mean, what would be useful for me at some point, maybe not now, is to sort of understand how, with this reconfiguring of services, including having maybe some more localised services, how that will affect the different main stages of cancer treatment. So we can see, actually, as well as getting clinical benefits from moving from Mount Vernon to Watford, that actually access benefits are there as well. I mean, is that the kind of thing that would be possible to pull together?
Yes, we've got quite a lot of the travel analysis, and I could have included quite a number of slides and tried to keep it quite short. But we have, and we've got the breakdown of how many patients from Hillingdon use different services as well. So if you recall the slide that I did keep in there, which had the how many patients use chemotherapy, not all chemotherapy would be able to happen at the Hillingdon unit, because the more complex stuff would still need to happen in the specialist centre. But the majority of that number would be able to happen at Hillingdon Hospital. So actually, for most people in Hillingdon, that's actually closer than the Mount Vernon service provides now. So we can take a bit more of a closer look at that, if you like, and send something to you. And a lot of it will depend on how many of the more local services we can provide. So we're still at relatively early stages with some of this thinking, particularly around things like blood tests and so on. That is going to rely very heavily on IT systems talking to each other, which I'm sure many of you realise the NHS has not got the world's greatest track record in, and that's something that we are going to have to sort out if we want to reduce patients' travelling times. From Hillingdon, it's perhaps not so bad as from some other areas, but some of the stories we've heard have been quite staggering, really, in terms of the length of journey time for such a simple, for a swab, for example. I think Ruth probably wants to come in on the back of that, if that's okay.
Yeah. Okay.
Yes, if I could, thank you. So one of the issues that we've identified, we've got a lot of information about travel times, which we'll happily share. But we're also going to be setting up a review of non-emergency patient transport. I think you might have noticed when we looked at the essential criteria that Jessamy presented, that public transport times, not in this area, but for patients in the north of the patch, can be upwards of 75 minutes on public transport. I think none of us would be wanting to do those journeys. So we'll be doing some work with ICSs to look at how we can improve that as well. So we'll share the scope of that work with you at the same time.
Thank you. That'd be very useful, because that's certainly one of the questions I think we will be asked. Because in a sense, the science is above all of our heads. It sounds very good, and it sounds positive in terms of improving the service that we can deliver. But that's a very tangible thing. My last question before I open it up to others is, you mentioned about obviously the capital funding and getting that sorted before we go to consultation, which I think is obviously a very good idea, because ultimately you don't want to raise expectations unless you know you have the backing of the system behind you. Will that mean that when you go to consultation, you'll be consulting on actually what can happen? Because the reason I asked that, because what you presented this evening does look very, very good, but obviously contains lots of parts. And ultimately, if some of the parts drop away, then maybe concerns that we don't have right now might arise, or they might not. So it would be useful at the consultation stage if actually what you're consulting on is obviously you have the actual what you have capital funding for, and then if there are others that you're still working on, that you make that very clear, because I think that's very important to the whole of the service. So.
Yes, absolutely agree with that, and we'll make that clear at the consultation point. As Jessamy's outlined, we are not able to proceed to consultation until we have a route to capital for the programme, but we'll make that clear in the consultation documentation.
Great, thank you. Right, I'm going to open it up to questions. Anybody can ask questions, doesn't have to be a council member. If anybody has an interest and wants to ask questions, you're very, very welcome. At the moment, Debbie has her hand up. Debbie, would you like to ask a question?
Thank you, Chairman. Thank you, Jessamy. It feels like so much has happened since we last spoke, because I think previously you were still sort of deciding whether to go for the one single location or the hub and spoke model, and yeah, it feels like a lot has changed. Are you able to tell us about how Hillingdon residents were responding in your patient outreach and how they feel about this move to Watford? And I've got few quick questions. My second question is about monitoring outcomes during the transition and how you monitor sort of, I don't know, time. I mean, I'm not a doctor, but the time to detect cancer and the success rate of the treatment. My concern is that at the moment there's a lot of cancer going undiagnosed because people aren't going to hospital because of COVID. And I fear that at the time you're going through this transition in September towards UCLH, you're going to have a burst of cancer cases, because people, in the coming months, as things start to open up, people are going to be more brave about, spotting cancer symptoms, going and detecting it and all the rest of it. So I wonder whether, how you're going to manage this sort of almost peak in cancer diagnosis and workload, along with this transition to a new provider. And the final question was, I think it was slide 19. I couldn't read it in time. You were talking about radiotherapy. I'm really not a doctor, so I feel a bit out of my depth here, but I think you were focusing on chemotherapy throughout it, but then there was something about radiotherapy moving to other places. And I think those hospitals, if I remember on the slide, they're not near us. Are you able to tell us a bit more about the radiotherapy?
Yes, sure. Shall I start with I can answer the first and last of your questions, and I think others perhaps will want to come in on the middle one. So I'll start with that last one, just to set your mind at rest about radiotherapy. So the radiotherapy slide was really there because we felt that there is radiotherapy is a service that we feel that people are there is a lower uptake of radiotherapy than we would like. It's a treatment that you are required to travel in daily for a number of weeks, so it's quite intensive in that respect. and there is a large part of the population that is travelling more than 45 minutes each way for their radiotherapy. So the proposal that we are working towards at the moment is that the main cancer centre, which under this suggestion would be at Watford, would have radiotherapy. So for patients in Hillingdon at the moment who would have radiotherapy now at Mount Vernon, in the future it would be at Watford. But they would have the option as well of going into Hammersmith Hospital if that was nearer for them. So not all to, it wouldn't be a case of just having to go north. There'd be an option to go south as well. And we are expecting that some patients will do that. And I think then for those in the most northern parts of the patch, so we're talking about Bedfordshire, Luton, East and North Hertfordshire, there is still quite a substantial need to have radiotherapy more accessible for that population. And we think that might well improve outcomes. And so we are looking at putting in additional radiotherapy. So the main unit would be at Watford, but there would be an additional radiotherapy unit that would be run by the Mount Vernon team, either at the Lister Hospital in Stevenage or at the Luton and Dunstable Hospital in Luton, because that's where we think the need is, above and beyond what we provide at the moment. So that's the radiotherapy one. In terms of what Hillingdon residents thought, so thinking back over the last 6 months probably of patient engagement, I would say that proportionately we've had a good response from the Hillingdon area, from people. I think overall I would love to see far more people get engaged than have got engaged, but actually given that Hillingdon makes up about 14% of the Mount Vernon population, I would say that well over 14% of the people who have taken part in the activities have been from the Hillingdon or Northwood areas. And between January and March I ran several workshops for people living in Hillingdon or particularly around Northwood and other areas to really try and establish what the impact of a Watford option might be. Hillingdon residents generally were quite supportive of an option that moved the service further north. I was expecting that not to be the case, and I was, it was one of the things that surprised me a little bit through the engagement that we did, that Watford was an okay option. They have raised some concerns about the availability of public transport between Hillingdon and Watford. I don't know the public transport very well, but we've certainly heard enough to know that there perhaps aren't direct bus routes, and we need to perhaps be having some conversations with public transport companies around perhaps making some changes to some bus routes or seeing what we can do from a public transport perspective. What I tended to find, I expected most people to kind of say we should move their service to their local hospital, whatever their local hospital would be. So I would have expected Hillingdon residents to say you need to move Mount Vernon to Hillingdon Hospital. We didn't get that. We got one or two people who thought that would be good. We got some people who thought it should stay where it was, but then understood why we needed to make changes. Most people actually understood that this is a really big population and moving it further into London wasn't going to do any good to other parts of the population. And I have to say I was really impressed by the attitude, and I still am, and the events that I have, of people that are thinking about everybody's needs and the impact of what we're doing on the whole population. So there were some concerns about access, if we picking on Hillingdon hospitals as an example, about access to Hillingdon being quite difficult. And I'm just having a little look at the notes. And there were some mixed views around some people's experiences of Hillingdon, some things that they'd heard, to be honest, whether there was enough space there. But generally speaking, it was felt that Watford was an okay solution, with the caveat around public transport. And we've had some very open conversations about the fact that actually Watford is further than Mount Vernon for Hillingdon residents, and we do need to pay attention to concerns around public transport and access and see what we can do. But there's been nothing in the events that have been really specifically to look at the impact of Hillingdon that have sort of flagged any major concerns. I don't know if that's kind of what you were looking for. I can send you more detail, and I can sort of send you numbers. I would love more people to get engaged. We've talked to some residents groups, we've talked to some patient groups, lots and lots of individuals. We had one of the local MPs at one of the meetings, and so we have had some good engagement. We can always do more though. So I'll stop and hand over to someone else about the cancer pathway, because I suspect that starts before we even get to Mount Vernon. If we're talking about diagnostics, there may be some colleagues from Hillingdon that would like to come in on that one as well.
I'm happy to take that as a starter.
Okay.
My name's Susan, and I'm the Managing Director for the Cancer Alliance, which serves Hillingdon and Hillingdon Hospital, and therefore I'm very involved with the Mount Vernon project on behalf of North West London Integrated Care System. So I think you asked about what happens when all of the people that we haven't seen so far during the COVID pandemic start coming out. And I think the first thing to say is that as an NHS, we would welcome that. We want to make sure that we get people that are unwell and need treatment treated as soon as possible, because we know that in pretty much any condition that will result in the best outcomes. In terms of making sure that we have enough capacity, we as an alliance share with the whole of North West London, including every single hospital, the number of referrals and the number of patients on the waiting list every week, for cancer, so that we can make sure that there's enough capacity and we're able to plan that. And that's very much the focus of the integrated care system, along with the Cancer Alliance this year. Our feeling is that for cancer, most of the people will come back in the next few months. And so as part of that, we'll be making sure that Mount Vernon have got enough capacity, as well as Hillingdon and our cancer centres, Imperial Hospital and the Marsden too. Does that answer your question?
Could I come in on this as well,
Yes.
Susan? And apologies, apparently my camera's not working. I've tried to play with it, so apologies for that. So
okay.
I think you've raised a really important question about transition and the additional risks that might arise during a transition time. So I think in addition to the work that Susan's described, we meet with the Cancer Centre every 2 weeks to audit some of the processes, which relates back to the recommendations that were put in place following the independent clinical review. So that work has been ongoing for about the last 18 months. We also review regularly the risk register of all the services at the site. That happens every month to make sure that the critical infrastructure is maintained. So there's a whole series of activities to give immediate assurance now about the services, and then to make sure that as we progress through the transition, we're maintaining the standards in addition to the performance standards. And then also thinking about what you were saying about outcomes. Clearly, we need to measure outcomes over a longer time period. So we will need to look at those over the next, year, 5 years in terms of the way that we measure the impact.
Thank you for that. And I think this is one of those issues that, in a few months' time, we'll be looking back on, looking to see what the real impact is actually. June, you had a question.
Thank you, Chairman. Radia raised one of the questions about the therapy. My question is about, I've got two questions. And thank you very much, because we're getting a better picture now of where we were previously to where we're going now. And it's becoming quite clear that the whole system is opening up catering for our residents in Hillingdon. But there's still a lot more we need to know in regards to how it's going to service the community in Hillingdon. I've got two questions. One is, in your slide you did, that was Jessamy? In your slide you talk about chemo going to Luton, or the nearest it will be for at Hammersmith Hospital. To go to Luton, that's a long traveling time for anyone who's going through any form of therapy to travel, have their therapy, and then to get back into the local area. You said there will be you're looking at some provision in regards to how you're going to enable that because of public transportation. So that's good to know. But obviously, sometimes some people fall through the net. So you need to be able to see how you can scoop up those people who may fall through the net with that. You said there are going to be some specialist provision at Mount Vernon. What specialist provision will that be? And the staffing level, the staff there, how many of those staff are still in post? Because I'm fully aware that a lot of the specialist staff has leave Mount Vernon the cancer centre, and there's not many specialist staff that is still there. One more question is about the capital funding. You said before anything starts, you're looking to make sure you have the capital fundings. If you don't get the full fundings as part of the capital funding, will there be private initiative involved in you looking to get finances for it?
Shall I come in on a number of those questions? So if I can take the funding question first. We haven't looked at the potential additional sources of funding, so we're still going through a process and discussions around identifying sources of capital. And then, so I'm afraid I'm happy to come back and update on that as that progresses, but we're not in a position, I'm afraid, today to be able to advise further about that particular point. In terms of the vacancy rate, the vacancy rate, and I've just had a quick look, the latest information I've got is of about 6 weeks ago, and the vacancy rate then is around 6%, which is not unusual and has not changed significantly over the last couple of years. It's one of the areas that we monitor specifically with the service. So I hope that's reassuring. I would need to find out if there are particular changes in various staff groups to come back to your point about the more specialised services.
Shall I just pick up on the back of that as well, in terms of I've been running some staff engagement events alongside some of the patient ones. In fact, I have a staff engagement event there tomorrow. And what I would say is that the staff is a very loyal workforce. They're very committed to the services, to their colleagues, to their patients, and they need some certainty. And I think they are hopeful, and they've used words to me like hope, like light at the end of a tunnel. They know something needs to change. They want to see something change, and they can see that we're making really good progress. So we've got a lot of staff that are hanging on, that potentially, if we weren't advancing the plans, in the way that we were, we might be at risk of losing. But at the moment, I think we're managing to keep those vacancy levels very stable through the development of the plans, through involving the staff in those plans. So I think the sooner we can get some certainty for staff, the better, because I think ultimately there is a risk if we're not able to do that, if this keeps dragging on and on, that there are other places that they can work that might offer them a bit more stability and a bit more experience at doing some of their specialist things. That they are frustrated that they can't do everything that they've been trained to do at Mount Vernon because the facilities just aren't available, or the support services. In terms of your question about Luton, Luton was in reference to radiotherapy, and that was rather than chemotherapy, but radiotherapy, that would be an additional service. So there would still be a local service. It would be in the main cancer centre, so it would be at the Watford Centre, and there would be an option for people living in North West London to have their radiotherapy at Hammersmith as well. So instead of having just Mount Vernon at the moment, if you live in Hillingdon, you would have the opportunity to have your radiotherapy instead at either Hammersmith or Watford. And then for those patients who live in Bedford, for example, they might have the opportunity for Watford or Luton, or Watford or Stevenage, depending on whether it was Luton or Stevenage that was selected. Chemotherapy-wise, we are looking to increase chemotherapy provision by having a new unit at Hillingdon. So actually that makes it easier for people in Hillingdon to have their chemotherapy treatment. I hope that answers your questions.
I think that what would be really good is when you come back to us, when you're in full consultation, there's a bit more detail about what the travelling time means, because obviously if you're in the south of the borough at the moment, I don't know what it's like to get to Hammersmith, for example, compared to Mount Vernon. So for us to have a feel, that sort of stuff would be really interesting. But thank you. Stuart, you've got your hand up.
Thank you, Chair. I wondered what the relationship would be in terms of funding. So if there wasn't the full funding available, how much of the new plans may be built into the redevelopment of Hillingdon Hospital, and how that might affect plans? And also, in terms of the consultation, how much in people's mind was it that we're looking at a redeveloped Hillingdon Hospital or the current version, when people's views were sought on locations of services and redesign?
So if I can come in on that first, and first of all give you some reassurance that we've been working very closely with a range of NHS organisations, including colleagues from Hillingdon Hospital, throughout this process. We have had initial discussions, as Jessamy and Susan have outlined, around the delivery of chemotherapy in Hillingdon Hospital, and had discussions about that. We have not yet got into the conversation about, if we don't get the full sums that we're looking for, what the mitigations might be around that, because we're still looking to actually deliver the programme in the way that we've designed it and that we would hope to consult on. So I can't answer again the question about the money and what we would do if we don't have access to the full amount of money. I'm hopeful that we won't get into that position, but if we do, we'll need to come back and brief you about that. In terms of the timing, about when the focus groups took place with patients in Hillingdon, I don't know, Jessamy, if you could pick up on the timing of that.
Yes, so the focus groups that I've been talking about have all taken place since October last year, which has been after the plans for Hillingdon have been public, and the plans for West Herts as well. And that has been subject to some questions that we've had in the groups, and I've worked quite closely with the teams at both those hospital trusts to make sure that we're being consistent, and that I know where they're at with their plans and can answer questions appropriately and so on. So most people that have taken part, some of them have been really well informed, actually, I have to say. Some members of the public that we've had on the groups seem to know an awful lot about the development plans and where they're at. Yeah, we've timescale wise, in terms of being able to have simultaneous conversations with local people about the plans and the different options and so on. It's worked quite well, I think, in that respect. We hadn't got this far prior to any new hospital schemes being announced or anything like that. It's all kind of worked quite well from a timing point of view.
Thank you for that. And obviously we would love you to come back once the consultation is published at some point during the consultation period, because there's been a big jump from the last time we spoke to you, but that'll be a really good time, because obviously some of the questions that we've had tonight will be crystallized. So that's an open invitation to you to come back when the consultation period happens. So I think at that point we'll leave the cancer service provision at the moment. So thank you so much for coming and speaking to us. That was really illuminating. You're free to leave, or you're free to stay, depending on what else you've got planned this evening. So we're going to move on to our next agenda item, which is going to be the Hillingdon Hospital rebuild. Who is going to start on that?
Good evening, everybody. It's Jason here. So if you're content, I'll start. We've got a presentation. There we go. Thank you. So if we just move on. So what we propose to do is just update you on the key headlines at this evening's meeting. So, gosh, last time we were here was September 2020. Huge amount's been done since then. So there's going to be a progress update by Rachel. Just a bit on the clinical model. So Abbas and Caroline, although Caroline's part of HCCP, we very much see her as part of the team as well. The design, the development and planning application, which Tahir, our estates lead, will be covering. There's a piece on the latest on the finances, which David will be covering, who's the finance lead. A piece again on the engagement, which Sarah, our redevelopment communications lead, will cover. And as we had in the intros, Neil McKay, who is our strategic advisor, has also joined us. So I'm quickly just going to do a bit of an intro. So here we just want to put a bit of context again on how do sort of new hospital developments work. The key piece for us is the Treasury, because they control the money. And so there is something called the Green Book, which very much is a tomb of information about the process all NHS trusts need to follow in order to secure capital funding for new hospitals. It is a three-stage process. So there is a strategic outline case, then an outline business case, and then a full business case. And it's going to sound a bit like blankety blank here. We've done the strategic outline case. So now we're on to the outline business case, and that's the piece we shall be updating you on. Just moving on. So the other bits that we just want to go through on here is very much looking as before, 21st century state-of-the-art hospital, and the designs are progressing at pace. We're very much doing that at a sort of trust level, working with all our clinicians, at a local, what is now referred to as place level, Hillingdon. So that's very much working with Hillingdon Health and Care Partners. And then at a system level with the North West London Integrated Care System. The other piece just to mention around that is that we are also working in close dialogue with the central team. There's a new hospitals programme team, which Rachel will be updating you on also. So that's my preamble just at the beginning, and I shall hand over to Rachel, our programme director.
Thanks, Jason. So I'll just give a quick overview of progress over recent months. So, I mean, as Jason mentioned, we've continued making really good progress since we last saw you, as we've moved to the outline business case stage. We've established a strong substantive team, which you can see on this slide, and we've continued working really closely with our partners across the system, not least the North West London Integrated Care System, for whom the redevelopment is a top priority. So moving on, I guess it's important just to note that the strategic outline case has now been formally approved by ministers. So we got a formal letter during February. As expected, it's subject to a number of conditions being met at the point of submitting the outline business case, and we've been actively working on those things over recent months. So one of the conditions you can see there was us needing to demonstrate that we have right-sized the building. So we've done lots of work on that with our clinical teams and with partners. We have been working with the North West London Integrated Care System on affordability of the scheme. We've got more work to do, but we're making progress. And also we're making sure that Treasury priorities are reflected in the design. So not least reducing carbon emissions. So they're the sorts of things that we have been progressing. The next slide then talks a little bit more about the new hospitals programme team. So as Jason mentioned, we've been working very closely with them. It's a team that is managed centrally by the Department of Health and Social Care and NHS England and NHS Improvement. It works in collaboration with trusts like Hillingdon, who are planning new builds as part of the National Health Infrastructure Programme. So that team have been developing and sharing best practice guidance, as well as bringing together the learning across all of the schemes within the national programme. So that's very helpful. They've reviewed the work that we've done to date, and actually we met with them yesterday to discuss that. And they acknowledge that we've been making very good progress in terms of taking forward their recommendations. And we all reaffirmed our commitment to work together collaboratively now over the next few months as we progress the outline business case. So a few other things just to report on. So we've developed what we call a schedule of accommodation for the new hospital. So that effectively maps out all of the space requirements. So it reflects the needs case, which we've developed, as I said earlier, with clinical teams, and that's been discussed extensively with system partners, and that includes the local authorities, town planners, and the GLA. So we've had a number of meetings with the planners. So that schedule of accommodation then has informed what we call the 1 to 500 scale designs for the new hospital. And they also reflect the feedback that we've received to date from the town planners, which Tahir will talk a little bit about later on. And when I talk about 1 to 500 scale designs, what I mean is really the first stage drawings. So they show where the departments and the rooms are, but they don't show any detail within rooms. That's the next stage. So we're preparing to share these 1 to 500 design layouts more widely with stakeholders. So we're planning to start that in late May, and Sarah will talk a little bit about that later on. And the feedback that we get from stakeholders will clearly then inform the more detailed design layouts that we refer to as the 1 to 200 and the 1 to 50 design layouts. So I'm going to just stop there and conscious of time, and I'll hand over to Abbas Kaku and Caroline Morrison, who are just going to say a little bit more about the clinical services strategy and some of the new models of care that underpin our plans. Thank you.
Okay, thank you. So I'm Abbas Kaku. I'm the clinical lead for the clinical strategy for the new hospital. So I'll make a start, and then Caroline can add if I've forgotten anything. So the trust, you can see the trust clinical services strategy was actually signed off by all our partners in Northwest London, including social care, about a year ago. And the aim of the new hospital is not to fundamentally change the range of services. So these will remain essentially the same as those that they currently are, but actually in a high quality hospital, reflecting the estate and the clinical adjacencies that allow the efficient flow of patients and the clinical models of care. The elements of the clinical services strategy there, so I think the clue there is that there are 3 key areas. One is on integration of the whole Hillingdon health and care, primary, community and social care services that are on offer for our patients. A lot about networking for services, for specialised services throughout Northwest London, and transformation, which is very much around the education, therapies, digital and workforce transformation to deliver the care, the health and social care that's required. To deliver that, we already have a vehicle to be able to deliver that, which is, of course, within the framework of the established Hillingdon Health and Care Partners, HHCP. So the idea is that the new hospital programme would dovetail into the work streams that already have been established and are continuing to be established as part of that partnership. And this is really important. So what that'll actually lead to is, by the time the new hospital opens, and probably well in advance of that, is that there will be more health and social care provided outside of the hospital setting than there currently is. But actually, for those patients who require a hospital setting, they will have a much higher quality of emergency and elective hospital care should they need it. Next slide, please. Yes, and one of the ambitions for the next year is to strengthen the neighbourhood teams that will be delivering this care throughout the borough. And I think finally it's about the use of the digital and workforce transformation as we've already talked about. And I think rather than go through the rest of this slide, because I think what the hospital will allow us to do is to facilitate the models of care that you can see described there, because at the moment the hospital, as you know, I've been a consultant there for 25 years, the departments are incredibly fragmented. It's poor, you get poor flow of patients, and it's not a very efficient setup. So the new hospital will facilitate those new models of care by having a better estate and by allowing those more efficient co-locations, so that patient care can be much more easily provided and coordinated. But 2 keys to the size of the hospital are really important, that under all circumstances, there's going to be a need for more diagnostic imaging, whether it's elective or whether it's emergency. So there will be an increase in the diagnostic services offered within the hospital. And I think the other area that significantly expands in the new hospital is critical and high dependency care, because of course, whereas more care will be provided outside of the hospital setting, should you require critical care, which is more likely with the population demographics, then you're more likely to require high dependency or intensive care. So those are areas that significantly expand in the new hospital. Caroline, I don't know whether you wanted to add anything to that I've forgotten before we move on.
Thanks, Abbas. The only thing I was going to just add to that was that really we're not going from a standing start on this with HHCP. So we have been working together as a group of providers in Hillingdon over the last 2 years plus, really. And unfortunately, you'll have me back again tomorrow to give you the HHCP update tomorrow. So I'm happy to obviously take any questions then as well.
It's a very interesting role you have, Caroline, so we're looking forward to seeing you tomorrow.
So we do already have some really fantastic models of integration around things like paediatric integrated clinics, where our consultant paediatricians are working very closely with our GPs to deliver care in primary care settings, which means that people don't have to travel to hospital. They can come into their local general practice, and also it provides sort of upskilling, education and training for our primary care clinicians as well. We have our discharge hub, where our local authority and community teams work really closely with the hospital team, and we've got care connection teams that work out in the community proactively case managing people that might be at greater risk of admission to hospital. So we do already have some of the building blocks of integration in place, and I think as we start to think around the delivery of the model of care for the new hospital, we've got some really real opportunity then to build on some of our ambition and take that forward. But as I say, I'll be here the rest of the evening, but I'll also be back tomorrow, so you will be fully HHCP'd by then.
Thank you, Chair. This is Tahir Ahmed. If it's okay, I'll continue with the presentation then.
Yes, please do.
Good evening. Thank you. So I'll touch on the design development as where we are at the moment. It's been mentioned already through the early part of the presentation. We're at a stage of 1 to 500 scaled layout drawings. Now, to simplify that a little further, what that does is it takes the functional content of the hospital and looks at it in a more through a microscope in terms of the schedule of accommodation and how the building is actually laid out, not just in its horizontal but vertical access, so the building operates as a whole. What we've done is we've successfully moved that level of detail into that level of design for the building, starting from the outside, working the way all the way through the building. That actually it does respond very much to the extensive engagement that we've had with our clinical teams, and that's led through Professor Abbas Kaku and the clinical cabinet. But also it's cross-checked against our clinical strategy and the clinical brief that we were set all along the way. So there's many checks and balances to ensure that the building not only provides an amazing environment in which to operate and deliver patient care, but also is consistent with the brief from the outset. What we've also done is we've taken those designs a little further, and through the engagement that we're having with the other stakeholders and the wider stakeholders within the NHS as well, not only do we follow national guidance, there are prescribed methodologies and building requirements that hospital premises should respond to, referred to as health technical memorandums and health building notes. The building in itself does respond to that, but we do look to take it further as new guidance and standards are emerging. It's not a surprise anymore, but we are adopting a net zero carbon approach to building hospitals. So the sustainability is high on the agenda here for the Hillingdon Hospital development, but also looking at modern methods of construction and how they can be used to not only facilitate a modern building feel that responds to a flexible need in the future, but also aids speed of construction and inconvenience as well. So looking at DFMA, such as design for manufacturing and assembly, off-site manufacturing, and the elements which also help not only that sustainability agenda, but look to deliver a hospital at pace as well. This is not to say we've just done this from a clinical perspective or a hospital perspective. We've had also some amazing engagement with our partners at Hillingdon Hospital, the planning team, and through an agreed PPA, planning performance agreement. We've been in an iterative process of sharing information, taking back and responding to the feedback that's been coming through the local authority to ensure that the building responds absolutely for the community as well. These meetings have taken place jointly. We've extended that a little bit further to have joint meetings with the Greater London Authority as well. And that is continuing as we work our way through the planning performance agreement and ultimately to a formal planning application for the hospital. As I said, we are at that 1 to 500 stage. We'll be moving into the more detailed stage of taking the schedule of accommodation to 1 to 200 stage drawings, and that is in collaboration with the Department of Health and Social Care, NHS England and NHS Improvement as well, who would look to challenge and review the designs along the way and respond in a very positive way to where improvements can be made or where innovation can be adopted as we move forward in the detailed design to procurement. We are now at that 1 to REBA stage 2. That's the Royal Institute of British Architects REBA stage 2, and we'll continue the engagement through that collaborative process, and of course continue to work with our operations and clinical teams as the designs develop. Thank you. If I may have the next slide. The next slide gives an overview of the processes that have been taken throughout the planning performance engagement. That will continue. We'll now be at moving into stage 4 of the planning performance agreement, which will take us towards the middle of June, and accordingly we'll respond to then, followed by a more detailed application. There's some dates on the bottom there which give an indication of when planning is to be submitted, which is in around September and determined around Christmas. Thank you. I'll pause there.
Thank you to hear, Chair. If I pick up the financial slide as a next slide, as stated by Rachel at the start of the meeting, the SOP was approved with a number of conditions, and one of which was a requirement to develop a balanced revenue plan for the new hospital. In addressing the affordability of the new hospital, we need to take into a number of factors, including the underlying financial position of the trust as a starting point, the additional revenue cost of the additional capital associated with the new build, plus any forecast additional costs that may be apparent in the 10-year planning period. And this refers to the Treasury Green Book requirement that Jason spoke about at the start of the presentation as well. Obviously, we've got mitigations to close those additional costs, especially the additional revenue costs of the new capital, and that is ensuring that the building is the right size, taking into account the demand and capacity and the new ways of working that Tahir spoke about, especially maximising the benefits of digital and maximise the benefits of new way of working that Abbas referenced with regard to patient pathways and clinical adjacencies of departments, that we've got the ability to plan right from the start. In addition, other mitigations on the capital side, looking at affordability, is looking at any potential land receipts that may be available from surplus land once a new hospital is up and running. And finally, making sure that we maximise the benefits of working across the health system in North West London to ensure that we make the most use of that new asset. As Tahir said, we're in the 1 to 500s, and we're moving to the 1 to 200s, where we continue to develop these mitigations to ensure that we can develop a balanced plan. At the moment, in the process of the OBC financial plan, that's still work in progress, and there's numerous discussions going on within the trust and across the sector to progress that balanced position and close any affordability gaps that may be there in the business case. At that point, I'll pass across to Sarah to pick up the next agenda item on engagement.
Lovely. Hi, so I'm Sarah Bowman and leading on the comms and engagement around the redevelopment. So just a bit of a recap first on sort of what we've done to date, and sort of how we've involved the community in that. So that the early stages were very much about building those relationships, making people aware that this was something that we were looking to do, and starting to get a lot of those channels of communication and engagement going. In terms of how successful we are, if we can just move on to the next slide in terms of what we did. So we started holding both public and staff webinars just to have that opportunity to explain what we were doing, and to have a Q&A. A lot of this, obviously, this has all been through COVID, so we have done an awful lot online, more so than we would normally have done, and I'll come on to that when we're talking about the next stage. We've had our public participation forum. This was something that we started to ensure that we have that public involvement in the plans. So we've recruited people from across the community. There was an open recruitment process. People kind of volunteered to take part in that, and it's very much aligned with the clinical cabinet working groups. So we've looked for people with sort of lived and recent experience of different services. So we've got young people on sort of the children and young people's group. We've got some pregnant women and people who've recently had babies on the maternity group, all the way through to sort of people who've just been through A&E or sort of had inpatient care, so that we can really get that feel, and the clinicians and the working group have that link into sort of patients as well. We've been doing a lot of community engagement, starting to sort of reach out with resident associations, working with Healthwatch to reach into schools, with the faith groups, putting things in different newsletters, all those different ways of reaching out into the community, letting people know what we're doing and how they can find that information. We've got the microsite going. We've been doing surveys on there, and as time progresses, we'll be making those sort of more specific on different areas. And obviously sort of the staff engagement and sort of usual social media that we've been using. So in terms of the next steps, I'm just going to the next slide. What we're looking at now is very much giving people that more tangible information, actually starting to look at things and being able to comment on what the hospital is going to look like inside and out. So this is really about building that enthusiasm, to update people on what's been going on, that sort of progress that's been made, but to get that feedback and planning. And that's for a couple of different stages. It's for the planning application itself, sort of supporting that, but also the planning of the design of the hospital and that more fundamental process that we're going through. So in terms of what we'll be doing at the moment, it's very much about preparing what we're doing. During May, we'll be starting to talk about the 1 to 500 plans that you've just been hearing about, giving some information on the clinical development. So it's not just about the outside of the building and that new building, but actually what's the inside going to be like, what are the changes to care, and how those improvements are going to be made. And then through June and July, and probably into August as well, we'll be holding a public exhibition, and that's where we'll have an awful lot more communications and engagement activity going on. Now, to start with, that public exhibition will be online, but we're going to be doing a lot of different things, a lot of outreach work, and as restrictions start to lift, we will actually be able to start to do some on the ground community engagement. Fingers crossed that we can do that, and we can do that safely. So on the next slide, I've got just a very brief summary of the types of things that we'll be doing. Now, I'm sure you imagine there is a far more detailed plan that sits behind this. There's a more detailed week by week plan of what we will be doing when. And this plan will also evolve. So as we get feedback on what we're doing, as more opportunities present themselves, as we sort of like identify different areas of the community that we need to focus on, we will very much add to this. But I just wanted to give like a very brief overview. I think the key to this for me really is about reaching far and wide across the community, people who regularly use the hospital, people who don't but might be future users of the hospital, staff and stakeholders, anybody with an interest. And it's about ensuring that we have really good involvement and engagement, so that we're giving people the opportunity to help shape those plans, and we're feeding back on that and showing people as we go along the route how their feedback and input is helping to shape it. And so we sort of retain that enthusiasm. So I'll just pick up a couple of points in here. So with our advertising, we're looking at things like Facebook, but also things where people who are not online will see them. So obviously got local community forums, we've got newsletters, Healthwatch Shopfront we've used earlier on in the process to promote there, things like the Heathrow Villager. In terms of the public exhibition, I've touched on this, but this is going to be wider than just being an exhibition to support the planning process. It will be talking about the sort of the clinical process, the clinical developments, services. It will be a bit of everything, and again, that's something that will start to evolve as people feed in. We will have it online to start with. We will do a video which we're going to sort of make available through community newsletters and things like that. And as I mentioned, really hoping that we will also be able to do some on the ground engagement, so that we are actually reaching out into the community. We can start to have a look at where we're getting feedback from. Are there areas of the borough that we're not really sort of reaching and getting feedback from? And so sort of starting to sort of target our work a little bit more there. The public participation forums will have another few of those. So we have 8 of those groups, of which 7 are aligned to the clinical cabinet working groups, and 1 is a communications and engagement forum to really understand how we sort of reach out across the community. The next few of those will be very much aligned to the progress or the plans that are going with the team, so that they are really linking into that clinical work. And then where I've talked about letters to local residents, this won't be across the whole borough. I just wanted to clarify that. It will be about those people in the immediate vicinity to the hospital. So where we're talking about our immediate neighbours. And obviously there's an awful lot more on there around work that we will do with our stakeholders and our internal audiences. Obviously there's an awful lot that we'll be doing with staff, because they're also our residents and patients, and a very, very important audience to us. So that is a quick canter through the comms and engagement, and I will pass back over to Jason.
Thank you, Sarah. So that's hopefully a whistle-stop tour of all the fantastic progress since we were last here in September, and happy to take questions now.
Well, thank you, Jason, and everybody else. That was a really good whistle-stop tour of what obviously is a big and complicated process, and you know, thank you to everyone involved in this, because obviously getting a hospital rebuild, I'm going to call it a new hospital almost, it is something that many people do desire, because yeah, anyone who's been to Hillingdon Hospital knows that it definitely does need it, and it does look like actually the plans are going forward very well at the moment. I've got a couple of questions, and I'll bring in some others. Firstly, I mean, this might be a difficult question for you to answer, Jason, but when do you think the plans might be solidified, and also when would you hope that we'll get the first spade in the ground and we'll have to wear hard hats visiting Hillingdon Hospital?
So it's sort of just following on from sort of Ruth's comments previously on the cancer piece. What we're sort of very cognizant of as a team is that we are fully aware of, potentially in the past, there's been a number of iterations of potential Hillingdon hospitals. One thing we are clear on as a team is we're not going to deliver a theoretical hospital. We are actually going to deliver the new Hillingdon Hospital. So with that, just that piece about the collaboration agreement with the centre, what we are currently in the process is absolutely making sure that we agree all the key pieces that we need to agree with them now. So when we go out to consultation, we can be very firm on all the key headlines. But to answer you, also,
I was about to say any day.
Maybe direct. So that was the politician's answer, probably.
Yeah. And I understand it's all.
The main piece, though, is that I have full confidence in the team and our colleagues that we're working with on various levels for construction. I hope to start in 2023.
Okay, and obviously for us, in terms of our next big steps for us, it's obviously when the expectations in May and the virtual tour, and hopefully the more real exhibition happens in June, July, when we can really get into the detail stuff. One of the things that I was pleased to hear about tonight was how you know, future clinical need and future delivery of service has been factored into the design, because ultimately you know, this is going to happen. I really hope it's going to happen, and you're doing great work. So everyone's doing great work. So it looks really good at what's happening at the moment, but ultimately you know, we need to make sure that the investment is future proofed, and it's designed in a way that can adapt and also go with the grain of you know, where healthcare is going. So I mean, could you expand a bit more? I mean, would you be confident that that's being put into the plans, the ability to sort of develop the hospital after it's been built, if you know what I mean, depending on the future direction of healthcare?
So if it's all right, Chair, I'll probably start and then hand over to here. I think the key piece in the sort of engagement that we're doing with local authority partners in planning is absolutely just along those lines of to give assurance that we're future proofing. So there's probably two elements to that: making sure that we are designing and going to build a new hospital in itself, which is a flexible building, but equally sort of co-adjacent to the hospital to ensure that we have sufficient space. We all know as health advances and developments happen, that any potential sort of new changes of care or new sort of ways of working, that could be physically accommodated on the site. But I'll pass over to Tahir, who will hopefully concur with me or disagree with me, but yes.
Thank you, Jason. I think you did a pretty good job, actually, so thank you. Yes, Chair, just to be more precise on that, the hospital is developed on a flexible grid, which allows that adjoining spaces can be converted quite easily and readily, and that doesn't limit it in terms of its mechanical engineering services as well. So in all intents and purposes, we are absolutely building a flexible building for the future that responds to the changing needs of not just healthcare, but actually advances in technology as well. And that's done through a form of building information management as well, where we have precise data about buildings and therefore be able to adapt them with minimum amount of what used to be sort of detailed exploratory work. The data is there now to help us respond more rapidly and efficiently. And as Jason says, yes, absolutely, as part of that consideration, we're looking beyond the envelope of the building as well to see how we can then add in future flexibility or expansion, if indeed that's required in many years to come.
Thank you. That's very interesting, actually, and quite exciting, actually. Intelligent buildings. We have intelligent motorways, intelligent fridges. Let's have intelligent buildings as well. And my last question for this part is a sort of a lot lower level question, but probably just as important to many people. What's the car parking situation going to be like?
So I'll pass that one and give that to Tahir, but hopefully, as ever, it's something that we have factored in and into consideration of probably working with the local authority and the GLA, plus sort of resident and staff feedback. But Tahir, do you want to just say the latest on the car park design?
Yes, absolutely. You'll be pleased to know that we've gone through an extensive amount of modelling and data modelling in terms of car park requirements, not just for staff. Hillingdon Hospitals is quite difficult to get to by public transport, and we recognise that there's no direct tube route, for instance. But we've done an extensive amount of data modelling in terms of transport modelling. We've also worked with our partners at the London Borough of Hillingdon and their advisors, WSP, and we are confident that the numbers that we've got to represent the appropriate amount of car parking required to service Hillingdon hospitals going into the future. One hopes, of course, our agenda in terms of the green plan, travel plan and the sustainability agenda will somewhat reduce that requirement in terms of car parking. But as it currently stands, we're in a good place in terms of the numbers and the size of the car parks that support the new hospital development.
I mean, is that equivalent to what we have now, more than what we have now? Less?
It is pretty much around the same numbers at the moment. It's been slightly difficult because COVID has, of course, obscured those figures for the year, but we've taken modelling way back to a few years before and, of course, now forecasting looking forward as well. But broadly, the numbers are about equal to what we have at the moment.
Thank you very much. OK, I'll open up to questions from other committee members. Stuart, you've got your hand up.
Thank you, Chair. Yeah, just so thinking about, let's stick on the car park theme. Planning, it would be useful to know when we'll find out more about the planning process or the managing process of quality of services, car parking, etc. during the construction phase. I'm not sure how much of that has to be built into your business planning for this stage, but it would be useful to start to hear. And I think people, when they're being consulted, are going to want to have some information about what happens while it's being constructed. And if I may just stay on construction, I have a few questions. But you spoke about carbon zero construction. Does that include then looking beyond construction and ensuring that the building and services achieve carbon zero beyond that? Because there's no point having a great construction that's environmentally friendly to then have a building that I'm sure it would fit with current standards, but actually goes towards the aspirations of carbon zero in the future. Chair, if I may come back to someone in a bit once those have answered, that'd be helpful. Thank you.
Thank you. T, are you happy to pick up?
Yes, I'm happy to pick that up. Thank you, Councillor, for your question. In terms of car parking and the strategy around the car parking and access to the site, yes, indeed, we are having those conversations around the phasing and the development of the site and the logistics of the site. Those will be developed as we get a construction partner on board who will actually be providing us with a whole construction plan as to how the logistics will work in terms of not just construction vehicles, but actually the operations of the car parking and the existing hospital as well. So it is a little bit work in progress, but of course there'll be a full management plan submitted to the local authority and as part of the wider consultation as well for review and comment. With regards to the second question, Councillor, if you would just remind me again specifically.
Around carbon zero beyond construction.
Sure. Thank you. Yes. Carbon zero is not just about recycling what most people tend to often think contributes quite a lot, and the use of photovoltaics, PV cells. We go beyond that. We look at sustainability in terms of the net zero carbon agenda, about embodied carbon within the construction process as well. So some of the techniques that we've looked at as part of the modern methods of construction is to look at design grids starting from the very subterranean levels of below ground in terms of the substructure and the superstructure of the building, and look at floor slabs and concrete construction that looks to minimize the use of embedded carbon. We also look at, of course, the more sustainable methods of building buildings with a life cycle built into those as well. So it really is started with the construction stage, but with the mind for life cycle management as the end goal that we're looking at. So net zero carbon is not an agenda for today, it's for the many years to come. And we would hope that those are, and we do believe that those are embedded within the Hillingdon Hospital building methodology that we've adopted.
So would it be, sorry, through you, Chair, would it be possible then to effectively imagine a kind of carbon zero hospital, including services in the future by, you know, not 2050 but 2030, for example? Are we working on that kind of ambition? Because my concern is that there's a lot of concentration on the physical premises when it comes to carbon zero, but actually the design may mean that some of the services are therefore emitting or taking more energy and other things, more waste. And I know it's hard in the hospital when everything has to be sterile. But, you know, it's that kind of reducing things so that design is environmentally unimpactful on the environment as much as possible.
Yes, of course. I mean, as part of the sustainability agenda, we do look at BREEAM in terms of building buildings of excellent environmental quality as well. In terms of that net zero carbon for hospitals, by the very nature of hospitals are very hungry for energy, power, the ventilation requirements within hospitals, the cooling, in terms of the theatre capacity, ventilation, etc., is always that much more difficult to achieve. The net zero carbon agenda is evolving at pace, and at the moment we are indeed responding to that. Although the final targets have yet to be fully established, the NHS will be driving forward its own net zero carbon sustainability agenda, and we're in dialogue with the national teams about being able to shape that so that it does deliver to those standards for the future as well.
Chair, if I may, with just a few more quick questions.
Okay.
So the one that may not be able to be quantified is in a different area. There was talk with the social care and health agenda moving services off site. I'm just wondering how many of those services, whether that's in percentage term or if there's particular key ones that have been moving off site, so as we kind of picture what the new hospital looked like, it helps us to get an understanding of what is being delivered elsewhere. And then just a very quick one on the consultations. I wonder if there's more conversations that can be had with the council about using its libraries and other public spaces to have designs and plans up, and you know, people can comment without having a member of staff there to facilitate that, but just having as much visibility as possible when we know that consultation has been difficult because of COVID or continues to be difficult because of COVID mitigation. So yeah, just continue joint working on every public building that the council has to display information about the hospital.
Thank you. I mean, if it's okay, Caroline, if you didn't mind picking up the new models, and then if Sarah just want to say about the engagement piece. I mean, if I just hand over to Caroline first, if that's all right.
Yeah, of course. I mean, it's difficult to kind of quantify in terms of numbers of services. I suppose I can give you a bit of a flavour of some of the things that we've been looking at. So I think it's less about, and it's also less about actually lifting and shifting services as they currently are. So you know, we know through the work the transformation that's actually sort of been accelerated around maybe the impact of COVID as to how we sort of work differently across settings of care and in sort of a less constraints around buildings, potentially looking at virtual models and how our clinical colleagues interact with each other, so that whereas we sort of previously might have talked about lifting and shifting wholesale outpatient activity, actually now what we're looking to do is, going back to my example around sort of paediatrics, would be how we make sure that our consultant colleagues and our primary care colleagues are actually working together to jointly manage people through community care. So that would either be through the GP practice, potentially in some of the estates in the community. So it's not a kind of a like for like move of a particular service from one location to another. It's actually through different ways of working and different ways of communicating between professionals and patients and carers and families. So paediatric integrated care would be sort of one example of that. As I talked about before, we've got our care connection teams and end of life teams, where we have our consultants working really closely with some of our community teams in the community, and that they might, some of that is patient facing, but some of that is actually working with our community teams, so that our community teams can sort of access specialist support to keep people well and in their place of residence. Some of the work that we might be doing around some of the Northwest London thinking is things like diagnostic hubs. So that is probably slightly more of a vision of moving where we might be able to access more diagnostics in a kind of a community setting. So that's a slightly more sort of visible move of something from one setting to another. But actually, by and large, it's less around taking a service and putting it somewhere else and more about ways of working. I'm happy to take any questions on that, because I know it's a slightly harder concept to describe than if I were to say, well, actually, we're going to deliver all of the dermatology outpatients somewhere else. That it's a very transformational way and a different way of working across different levels of care and health in the community.
Caroline, you're coming back to us tomorrow to talk more about your role in depth, aren't you? And
I am, yeah.
How that works. And so I reckon that would probably be a good time for us to sort of delve into that.
Sure, yeah.
Thank you. Sarah, you weren't coming in?
Yes, so just on the point about engagement, absolutely. I mean, there is no such thing as too much engagement. So as far as we can reach into sort of everywhere in the community, now your libraries are open again, we're looking there. So what we're looking at doing at the moment is, well, I've been speaking to your to the council comms team, so that's fantastic. So we've been working with them through COVID anyway. So having a look at all those different places, the leisure centres, sort of is there information we can also put up in sort of the COVID vaccination centres, in sort of like the areas, waiting areas, sort of end and beginning. So we're looking at all these different places that we can do. So I'm more than happy to kind of share a more detailed plan as and when, and sort of take any suggestions that anyone has.
Thank you for that. Simon, you've got your hand up.
Thank you, Chairman. You've actually answered some of my questions already, but Jason, you said you hoped that spades would be on the ground by 2023. At one of our previous meetings here, it was suggested that the hospital would be complete and admitting patients by the end of 2024. Is that still the target? That's my first question. And my second question is around team stability. It looks like you've got a pretty stable team at the moment, but I know in the past there has been some problems with team stability. So I just wanted to know how that's looking now and if you feel confident in the people that you've got around you. Thank you, Chairman.
Thank you. So to pick up on the first piece about the timelines, the key probably material piece that's changed since we sort of went through in depth here in October is the establishment of the new hospitals programme team. So very much they are adding value. But what is part of the process at the moment is, how I put it is, we are testing everything with them now, which will then ensure that we then agree all the key headlines over the next couple of months and then be able to go at pace. There is in that collaboration agreement sort of a key piece about who does what through the process. With that and with that process, yes, our latest sort of thinking is the potential that it will be 2023 that we start, and that's just the way of making sure that everything is landed in the correct order. And then if you work through the same sort of timelines that we did previously about how long the build would take, that would then look to 2026 for when it would be completed. Team stability, absolutely. So I think there's been many honest reflections around the local community around actually the delivery of the new Hillingdon Hospital has gone through a number of it's got so close, but it never quite got there. And one piece that we've certainly learnt from previous sort of schemes is to really ensure that there's a top class team that's appropriately resourced and is there from start to finish. So what we have done this time is, if you look at the sort of calibre of the team here, not saying anything about previous teams, but pretty much you've got the sort of best people you can get currently working on the scheme. With those, probably a really good sort of top-notch suite of consultants, and then very much working in partnership. So I think from a team perspective, absolutely, we've taken on feedback from certainly yourselves about previous schemes, and we hope this time that we've established ourselves that the team will actually go from strength to strength.
Yeah, no, I mean, just on that, I'd like to say thanks to everybody for being open and transparent. And I think for me personally, one of the indications of top quality people is they don't mind probing questions and are happy to be transparent. And definitely over the last, certainly since I've become chair anyway, and before even, it feels like I can approach anybody and ask them any questions and I'll get honest answers. And I think that, seems really healthy. And the presentation today was very quick, but also very rounded, I thought as well. So, so far so good. So I'll ask one last question on this agenda item, which is sort of a tangent. It's about Mount Vernon, actually, because obviously the first agenda item was about moving a significant service away from Mount Vernon. And Mount Vernon is obviously a lovely site with lots of potential, but it feels a bit like a Cinderella at the moment. So is there a strategy being developed for Mount Vernon?
So if we look at very much in our title, it's Hillingdon Hospital. So it's two hospitals, Mount Vernon and Hillingdon Hospital. The key piece that when we go into the consultation that will become clearer is, and it sort of ties in part with the car parking and other discussions earlier. Whilst we're building the new hospital, we will very much be utilising the Mount Vernon site more over the next few years. And so in effect, what people will see in reality is probably Mount Vernon being busier. But we're also very aware that once we've sort of completed the business case for the Hillingdon Hospital and we've got the sort of diggers on site, we will be going through sort of a similar process with the Mount Vernon, link it back to that earlier discussion about probably in a year or so, if those timelines that we talked about earlier when UCLH have potentially taken on the service, we will be in dialogue with UCLH, a number of partners at a Hillingdon level, a number of partners at a North West London level, sort of in that sort of 2022, 2023, to then look at how the Mount Vernon site goes forward. So absolutely, we're very cognizant of that.
Brilliant. Look forward to hearing more about that in the future. Well, thank you everybody for the presentation. We're going to move on to our next agenda item. Obviously, people are free to stay or free to leave depending on what they've got planned. So we're going to move on to number 7, which is Hillingdon Hospital NHS Foundation Trust Performance Update. Patricia, are you going to be leading on that?
Yes, I am.
Fantastic. Before you start, can you just introduce yourself to the committee and a bit about your background? Because I think this is your first time talking to us.
It is. Thank you very much for inviting me. So I'm Patricia Wright. I'm the Chief Executive at Hillingdon Hospitals NHS Foundation Trust, and I've been in the Trust since the beginning of December. Until before then, I was Chief Executive of Hounslow and Richmond Community Healthcare Trust, so a partner organisation for around 5 years. But I do have actually quite a long history with North West London. I was a PCT Chief Executive in Kensington and Chelsea, and I was also Director of Strategic Commissioning across the 8 PCTs in North West London prior to that. So I've known Hillingdon for quite a long time, although not actually worked at Hillingdon Hospital, and actually was very pleased to be asked initially to come to the Trust as the Interim Chief Executive, and then when the job was advertised as a permanent post, made the decision that I would like to apply for the permanent post and was very pleased to get it. So thank you for inviting me to come and talk a bit about performance of the Trust this evening. What I have is I have a few slides, but I think rather than give you another set of slide presentation to go through, what I thought I would do is just use them as an aid memoir for myself and be able to link back to the very red charts that you have in the papers available for this meeting. So I thought I would start by just giving a bit of the background to where the Trust is, and starting by saying that just to remind everybody that in 2015 the Trust was inspected by the CQC, was rated as requires improvement with good overall for caring. And I think I was around the North West London patch at that time, and I think, like many other organisations, Hillingdon had become a foundation trust in 2011, had was developing itself as an organisation, probably felt requires improvement, was a kind of okay place to be in 2015, but had aspirations to improve its performance over the following years. What in fact happened in 2018 was they were inspected again by the CQC, and I think it would be fair to say, much to the organisation's surprise, although if you look at the ratings by the CQC, there was good performance and improved performance in areas like maternity, children's services, and ABBAS is on this call, and we have an amazing children's service and a very, very good maternity service. But actually, urgent and emergency care and surgery, their performance went backwards, and in fact we were rated as inadequate for both safe and for well led in those services. So what that meant at the time was that the Trust was rated as inadequate on the Hillingdon site. Mount Vernon wasn't inspected at that time, so it remained with its score of requires improvement, and that gave the Trust a score of requires improvement overall. I think what that inspection highlighted was long-standing performance issues which the regulator was aware of, particularly around finances and particularly some of the performance around emergency access. But what the Trust did at that time was they put a comprehensive action plan in place, and there was actually significant progress made against that action plan during 2018-19 and 2019-20. And that was largely because a completely new leadership team came into post. So there was a new chief executive, a new director of strategy, and that's Jason, who's with us tonight, a chief operating officer, medical director, or director of nursing, and others. So, Tahir, who is our director of estates and facilities. So a big change in the organisation at leadership level. And going back to Councillor Arnold's comment about stability in the organisation, I think I can absolutely understand your concerns about that. What then happened and I think it would be fair to say that I think there was an expectation as we went into the last financial year, so 2021, that there would be a CQC inspection in the year. And in fact, the Trust was asked to pull together. You have to answer a number of questions for the CQC when they give you an indication that they're going to come to inspect, and we had already submitted our information for that. And then, of course, what happened was that COVID hit. And during March to July last year, the Trust operated in the first wave of the COVID pandemic. I think the organisation was really quite fragile. The pandemic had a really big impact on both Hillingdon and London North West. They were trusts that were hit pretty hard in the first wave of the pandemic. And we had enormous issues about matching our activity with capacity. So our ITU capacity, we're funded for 9 ITU beds. We actually had to move up to 15 beds in the first wave and in the second wave of the pandemic. And that meant that we had to move into our theatre facilities in order to accommodate patients who needed non-invasive ventilation or mechanical ventilation. We had high levels of staff sickness. Really, it was all hands on deck, so staff got moved to areas they weren't necessarily familiar with working in, and staff who didn't necessarily work in clinical roles but had clinical backgrounds put their uniforms on. And that was in a phase when, as a nation, we were learning about what this pandemic meant for us, and there was changing guidance on a regular basis. What it did do is it brought into stark focus the impact of the poor estate on the ability to deliver safe care. So our ability to segregate care pathways into infectious and non-infectious was really limited by the narrow bed spaces in the tower wards, our ability to create clear flow through A&E, and that is still an issue, and crowding at our front entrance. And then thirdly, the impact of COVID on the delivery of our constitutional standards. So in fact, the A&E performance improved at the beginning of the pandemic because the public were told to stay away from A&E departments, and you can actually see an improvement in our performance. But actually, as we came out of the first wave of the pandemic and people started to come back to A&E, and we've seen the same again in the last few weeks, our performance deteriorated again, largely a combination of numbers, flow, and our ability to staff our A&E. And what we also saw through the first wave of the pandemic was an increase in elective waiting times, both in terms of size of the waiting list and the length of wait. And that was from actually a very good position in terms of long waiters at the beginning of April 2020, where we'd almost entirely eliminated our 52-week waiters. Through the pandemic, we're now back to over 1,000 patients waiting over more than 52 weeks, although actually there is quite a good story developing around that. What then happened was in July 2020, there was a COVID outbreak which involved a large number of staff and led to restrictions in admission to respiratory care. So our A&E wasn't closed, but we weren't in a position to take patients who needed non-invasive ventilation. And that then followed in August and September by unannounced inspections to predominantly our A&E department and to our respiratory ward, where both the CQC and the Health and Safety Executive identified failings in relation predominantly to infection prevention and control. So we were issued with a Section 29 and a Section 31 enforcement notice. The Chief Executive, the Medical Director and the Director of Nursing subsequently moved on from the Trust. And NHS E&I asked Leslie Watts, who was on the call earlier on, who is the Chief Executive of Chelsea and Westminster Hospital and also the lead Chief Executive for the Integrated Care System in North West London, to provide specialist advice to the board. And as part of that, Leslie supported the board by identifying support for the organisation as a whole. And there was an improvement plan implemented as a result of that with intensive monitoring. So we do weekly returns to the CQC in relation to that. Then in December 2020 till fairly recently, we moved into the second wave of the pandemic. And in that period of time, I've started in the organisation. We have a new medical director, a new director of nursing and a new director of finance. And we've also had targeted support from the senior team at Chelsea and Westminster and from the integrated care system partners. And what we've seen in the second wave was an even higher number of patients presenting to the trust with high pressures on capacity. So just to give you an example of that, at the peak of the pandemic in April, we had around 100 patients diagnosed with COVID in our inpatient beds at any one time. In December and January, the peak was about 160 patients and sometimes up to as high as 180. So huge pressure on the organisation. However, what I would say is I wasn't at the trust in the first wave, but I think the staff would reflect that they were more prepared, and we were able to use, as a sector, we were more prepared in that we were able to provide more mutual aid to each other. So if Hillingdon was in trouble, we would be able to have a divert to another hospital, or we were able to transfer patients between different organisations to relieve pressure on our ITUs particularly. So that's a bit of the context of where we have been in the last couple of years. And what does that mean in terms of performance? So in terms of quality, I would say that COVID affected the quality of care at all levels across the organisation, but the Trust has continued to monitor performance and has maintained quality in a number of areas, such as falls, pressure ulcers, which are all often an indication of just general care in the hospital. Communication, I think, has been a huge issue during the pandemic, in part due to our inability of carers to attend with patients and to be able to visit their loved ones in hospital. And kind of in response to that, although we put a number of things in place, like having iPads on wards, and in the initial phase having volunteers who could answer the phone and those sorts of things, that communication has not been as good as it can be. And I think that's been a reflection for us as an organisation about going forward, how do we make sure that we communicate better with our patients and their families, but also what we need to do if we end up in a third wave of the pandemic. What's also been a problem is that complaints response times have been very poor, and we've taken action more recently and we've seen a step change in our performance during March and April. So we had 100% responses within the 30-day or 45-day timeline in March, and we've only had one breach of that timeline in April, and that was only by 1 day. And it's an area I am particularly concerned about. I think patient experience is enormously important. And that, I would say, probably is the area where we haven't performed as well as we should do through the pandemic. We've responded to the enforcement notices, so we've made changes to the we've refurbished and made a new changing area in A&E. We've improved our signage around the hospital. We've done a lot of work on staff protection in terms of fit mask testing. We've done risk assessments around the hospital, and we've also done individual risk assessments with staff in relation to what we call vulnerable staff risk assessments, and that's also influenced whether or not staff have been able to come on site or whether they've had to work from home. And we've done a lot of work around agile working to facilitate people for working at home. And we've had very tight controls on the back of the fact that we had an outbreak in July last year around managing nosocomial infections. That's where you get infections as a result of being infected by another patient or a member of staff in hospital. And I'm pleased to report that we were able, you have to report nosocomial infections until you've had 28 days clear from the last reported infection. And we were able to clear all of our nosocomial infections as of last week, which is a really good place to be. In terms of constitutional standards, very quickly, emergency performance continues to be below the required standard. As I said, it improved when the number of people presented dropped, but we have huge impact on our space constraints in the A&E department. And particularly our need to segregate patients who have or had potential infections and who are not infected. and as we've seen, we had improved performance for a period of time. As we've come out of the pandemic, we are starting to see numbers increase enormously. Last week, we were seeing presentations at A&E that would be equivalent to a busy winter's day. And it does feel a bit wintry still at the moment, but we're certainly not in the middle of winter. And that is something that we're going to have to manage very carefully so that we don't end up with people being too close together or getting cross-infection between patients in A&E. But huge credit to the A&E staff. A&E and our ITU staff have worked incredibly hard during this, and they are tired. And I'll come back to that when I talk about workforce. In terms of waiting lists, the 52-week patient numbers have increased from very low numbers up to around 1,000, but we're actually working really hard locally and with our partner trusts in North West London to reduce those numbers. And we are into what's known as spring planning. So we have a recovery plan now that we can restart our elective work. And we are ahead of our target in terms of reducing the numbers of people waiting a long time. We have also kept on top of the waiting list. So in phase 2 of the pandemic, what we did was we very consciously kept Mount Vernon as a green site, and we're able to use a number of our staff who were shielding and therefore needed to be in a protected environment to continue operating at Mount Vernon. So we've done a lot of day case work during the second phase of the pandemic. So we are ahead again of where we expected to be in terms of elective work. And then finally, just around cancer, we are meeting the majority of our targets, and particularly those that we have control over. So some of our patients are on 62-day pathways where part of their treatment would have to be at a tertiary centre, but actually we're doing well in making sure that patients who are on a 2-week wait pathway where there's a suspected cancer, that they're seen in a timely manner. So some of the questions earlier on about how are we managing during the pandemic, I think better than we expected to in the phase 2. In terms of our people, who are really our most important asset in all of this, I'd like publicly at this meeting to thank our staff for their dedication and hard work throughout the pandemic. I visited well, we've been having listening sessions with our staff over the last few weeks, and it was really rewarding today, first of all, in a visit I made to A&E, to hear of reception staff who gave up Christmas Day, who worked extra shifts, who came in when we were short-staffed because their colleagues were unwell, and really kept services running. And the same applied across the trust. People literally did, get into uniform, go and help in areas they weren't familiar with, staff who were really anxious about their exposure to patients who had COVID, put on protective equipment and kept the hospital running. And I don't think we should forget that actually staff were very affected in many ways. So, all of us have been affected by COVID. It's affected our personal lives. And we had staff who were really very frightened. They came into work and did what they needed to do for patients, but they were actually very frightened about taking COVID home to their families. And it's massive credit to them that they've kept going. Throughout that, actually, what we found across the NHS is that COVID has reduced turnover in our staff. We've done well in terms of vacancy rates, in that our vacancy rates are continuing to drop. And in fact, we've been really pleased that throughout this period, we've really pushed on continuing to recruit to vacant posts. And we've got around 65 overseas nurses who will join us in the next 12 months and are being phased in at the moment. And we recruited around 70 healthcare assistants who are all now in post. So actually, we've made quite a significant impact on our vacancy rates. Still more to do. But again, I heard a presentation from our therapies lead today where they're finding that actually they've had some very, very difficult posts to fill, and they're managing to fill those at the moment. So that's a very good place to be. We had high sickness rates during COVID, but actually those numbers have dropped significantly now. And actually we've had some impact on some of our long-term sickness, which has improved over and above the COVID sickness. And then something I think you probably will be interested in We were a staff vaccination hub both for our staff and for a number of our partner organisations locally. We've done incredibly well on vaccinations in general. We have currently vaccinated around 83% of our staff, but we're not giving up on that. We want to get over 90% of our staff vaccinated, and we're continuing to work on identifying staff who will come forward for vaccination. So just a couple more things I wanted to highlight. You've heard a lot about our estate this evening. What hasn't been mentioned is the fact that as a part of our redevelopment and part of a commitment to facilitating that and supporting the fact that it's been acknowledged both in North West London and across the NHS that the facilities at Hillingdon are really not fully fit for purpose. We have 2 modular builds that are underway at the moment. Modular North is almost completed now. We've had a ward in the lower part of that for some time, but we are planning to move our ITU and our respiratory facilities into that facility this month, and that will make an incredible difference to the quality of facilities we have for some of our most critical patients, particularly again if we go into a third wave of the pandemic. And it also gives us the capacity that instead of having to flex into theatres, if we have to increase our ITU capacity, we have flex capacity in that new facility. We've also been doing planned refurbishment of the tower wards. That's part of an enforcement notice that we have by London Fire Brigade. But what is really positive is that we've used the fact that we needed to improve our fire safety to take the opportunity to refurbish those wards. And we've got a phased and planned process underway. And in fact, we've had really positive feedback from London Fire Brigade about that. And we've just signed a memorandum of understanding with them, which is a really good place to be. We've upgraded and are recommissioning our incinerator. And we've already, as I said, covered quite a lot around the redevelopment. So 2 final things. Money. Essentially, we ended the year in a balanced position. We had 1 impairment that was partly due to re-evaluation of our facilities, but in terms of our baseline funding, we will come in at a balanced position. And quite a lot of that, there's been some really good work around looking at our efficiency, but we that's also been facilitated by additional COVID funding that was applied to the whole NHS. But I think it is important to understand that we still have a significant underlying deficit that needs to be addressed, and it will need to be addressed as part of our work to develop the outline business case for the redevelopment and the full business case. And then finally, just to say, so what next? We do have a new team in place, but I believe that we are an experienced leadership team, and there is an absolute commitment to making Hillingdon Hospital's NHS Foundation Trust a great place to work and a great place to be treated. I think we've learned a lot from the pandemic about how we can work differently and how we can work much more closely with partners. And as a community trust chief executive, I was used to working in partnership with, in my case, West Middlesex Hospital and Kingston Hospital. But you know, I'm absolutely delighted with the level and depth of partnership working there has been with our partners in Hillingdon, Central and North West London Trust, our GP practices, and actually we couldn't have got through this pandemic without that really close working together. We've done a huge amount of thinking about how we can get patients discharged safely, being able to hand patients safely onto a community pathway, those sorts of things. And we won't let any of that go backwards. It's a really positive place to be. We're clear about what needs to be delivered in this next phase, and our focus has to be on quality, people, both our staff and patients, and keeping an eye on the money, but we'll do that in partnership with Hillingdon Healthcare Partners and across North West London. So that's all I wanted to say. I hope that's given you a sense of where we are, and I'm very happy to take questions.
Well, thank you very much, Patricia, for coming along and the comprehensive presentation you've just given us, because you know, it's very, very important. Obviously, as you know, from going through the history of 2015 requires improvement, then 2018 again requires improvement, and that was a disappointment. And of course, again, we had this sort of section notices recently. And again, that was disappointing. Obviously that's against many people's personal experiences of having great service at Hillingdon Hospital and being treated very well there, against this overall sort of bigger issues that get reported on. And I think the estate doesn't help that, because you hear about the sort of notices and then you see the estate and it just doesn't all fit together very well. So it was really great that you've given us that comprehensive presentation, because I think we're yearning for things to get better on that sort of scale. So from my personal perspective, I'm sort of putting a line under all the previous stuff, and I'm really interested to see how things go over the next year and the plans that you've put in place and how they come to fruition. So I've got a couple of questions, and then obviously I'll open up to other people. My first one is, you mentioned the improvement plan. If you could pick a couple of key aspects of the improvement plan which you think would be important to helping the CQC whenever they visit again to bump up our performance, what do you think those key improvement aspects would be?
So I mean, we've had a very comprehensive improvement plan. So it's huge. It's 64 pages and a lot of really, really good work. What we've said is that actually what we need to have is not just respond to what the CQC said, but we need to actually set some aspirational plans for the organisation. And in fact, our Director of Nursing has come from Chelsea and Westminster, where she actually ran the Chelsea and Westminster response to CQC. And you're probably aware, but CQC have a series of key lines of inquiry around safe, caring, effective, those headings. And essentially what they do is they give you a descriptor of what the trust would look like if you're inadequate, what if you would look like if you requires improvement, good and outstanding. And essentially what we're doing at the moment is that we're very systematically looking at those CLOEs at service level and saying, what do we think the gaps are? And then splitting those into what are the things that we can do quickly that, are almost kind of no-brainers. And then what are the things that need much more focused work with the teams and will need improvement. But what we're trying to do is set a stretch target to say, what would getting to good look like and what's the journey we need to take to get there? So we're not being naive. This is a journey. There's lots to do as an organisation. We have a very demoralised group of staff. So our staff survey that was published recently shows us as one of, against our peer group, we've got very low morale. Staff wouldn't recommend the trust as a place to work. They wouldn't recommend the trust as to friends and family. Now, actually, we think we can turn that around, and we think we can turn that around by getting staff to think about how they can rebuild their pride in the service. And some of that is being able to say, if it's about, so if I take something like SAFE, we absolutely have to tackle safe services. Now, I see safe services every day in the hospital. If you walk around, there's really high quality care and there are safe services. What the CQC will be looking for is that staff can articulate what a safe service looks like. So they can say things like, when something goes wrong, we fill out an incident report. That incident gets investigated and then we get feedback on what's been done as a result of it. And we learn from that feedback. And so that's the sort of thing where the CQC would say, there was no evidence of audit, there was no evidence of learning from incidents. So we're doing a lot of work at the moment about, have we got that infrastructure in place to make sure the staff are getting regular feedback from incidents, that they can articulate what safe looks like, they can say they do audits. It's that sort of thing, that they can give examples of what caring looks like, so that, someone can say, I'll give you an example. So we have one of the consultants in paediatrics who has just developed a service for neonates out in the community. It's absolutely innovative. There is nowhere else in the country where that's going on. It's been developed to support women who've had premature babies when they go home, which is an incredibly anxious period of time. And GJ, one of our consultants, has set up a system in the community. That's the kind of example we need to be giving to the CQC to say, this is what a really high quality hospital looks like. So it's that kind of stuff that we need to do. We won't be able to solve everything. We haven't gone back to the CQC to say we'd like them to take our improvement notices off, because we feel we've got a bit more embedding to do at the moment, and I'd rather we were honest with ourselves and say we've got more to do than just say, oh no, come back in and have a look. You know, on a busy day in A&E is very crowded and very busy, and we've still got more to do on that. So I want to make sure that some of this stuff is embedded before we say, yeah, it's all okay.
Yeah, no, that sounds like a good approach to me, and some of the stuff you were talking about sort of feeds into my next question that I wanted to mention, which is one of the things that really struck me in the 2008 CQC report was the criticism in the leadership, essentially, and the culture throughout the organisation. Leadership and culture is one of those important but difficult things to sort of tackle, and in some of your answers actually you've already talked about how you're getting there in terms of listening surveys and basically highlighting the great work people do and all this sort of stuff. But maybe if you could give me a bit more detail about the leadership style that you want to embed throughout the Hillingdon Hospital, and also the type of culture you're trying to create, that would be really useful.
So I have a performance background. I'm a pharmacist by background, and have worked my way through the leadership system through operations. So I'm used to being beaten up about A&E performance and those sorts of things. And I come from a background where precision is very important. You know, when you get your pills from your local pharmacist, you don't want them to go, oh, well, you can just take a few of those. You want them to tell you how many you need to take and at what frequency. So that's my background. My approach is very much about, we need to create a framework that people work within, and they know what the governance framework is, and they're very clear about how much they can push that framework. But within that, what we have to do is let staff take the lead. And that's very much my approach, which is that I want us to do with staff, not to staff. And it's very interesting that as we've been doing listening sessions, so just to illustrate, one of the things that's I think very distressing actually is that if you look at our staff survey since 2016, the indicators show that that staff perception of what it's like to work in the organisation has been deteriorating. And if you look at our comparative organisations, most of them have either stayed flat or gone up a bit. And actually even the worst, the trust with the worst scores in the staff survey, actually during COVID, perceptions of the organisation have gone up. And that isn't the case at Hillingdon. And when we've arranged a number of listening sessions, and what's come back really strongly is the churn at the top hasn't been helpful. That they're not very clear about what the vision for the organisation is and where we're going. And they want to be allowed to get on and do stuff. They want autonomy to get on and do stuff. So actually that's relatively easy to deal with. You know, what we're creating at the moment is an infrastructure that supports staff to deliver the very best care they can. And my approach very much is, you know, if I'm coming in to think it can only be me and the executive, then we failed on day one. We've absolutely got to engage the whole organisation. And it was something I did at my previous organisation, and in fact was very proud of the fact that staff engagement at Hounslow and Richmond was actually very high as a result of that approach to let staff take it forward. So it's not that we won't strive for excellence, and it's not that I won't be continually pushing people to do stuff, but it will be about bringing people with us. Absolutely.
Thank you for that. Do we have any other questions? Simon.
Thank you, Chairman. Patricia, thank you for coming to see us today. I've been on this committee for 3 years, and I've almost lost track of how many changes we've had in the senior leadership team. In fact, so much so it's almost become a joke within the committee of we wonder who the next senior leadership team is going to be, and everyone that comes in front of us says very eloquently, just like you have, that they're implementing changes to move the trust in the right direction. And all that seems to happen is we seem to go downhill, downhill, downhill. Now, I recognise that the last 12, 18 months has been particularly challenging because of COVID. But and it's a question I've asked to every time Hillingdon Hospitals come in front of us. When do you anticipate that A, the hospital will be able to deliver completely safe care, and more importantly, when particularly A&E will become good to excellent? Because in the past we've had people say, yes, the next time we come and see you, or within 6 months, within 12 months, our ratings would have changed from inadequate to good or to excellent. So sorry if that sounds a bit harsh, but it's been really frustrating over the last 3 years that we keep hearing the same sort of, oh yes, it's all going to be brilliant, and within 3 months it will have changed it, and it just seems to be getting worse. And I'm frustrated about it. I know the residents are frustrated about it. I'm sure the rest of the committee is frustrated about it. So yes, I'm sorry if that sounded a bit harsh, but it is incredibly frustrating.
No, I think it's an absolutely fair challenge, and actually, why wouldn't the local population expect to have high quality care? I mean, I wasn't at the trust, obviously, at the beginning of April last year. I don't know, but I think if we hadn't had COVID, I think the trust would probably be in a better position than it is now. So, I think there was, in credit to the previous team, I think there was a very clear focus on improving performance in the trust, and COVID hasn't helped, and the events that happened last summer haven't helped either. And I think it would be fair to say that Hillingdon, the issue that occurred in Hillingdon last summer was not a good place to be, but I'm sure there were plenty of other trusts around the country who were very relieved that it wasn't them that got the visit from the CQC. And one of the things that I think is very encouraging is that actually we are now starting to be used as an exemplar in terms of the level of monitoring we're doing and the processes that we've got in place. So I think that's encouraging. I'm not going to say to you that if CQC walked in tomorrow that they wouldn't say our services weren't good enough still. I think we are still in the kind of post-COVID phase. I went into A&E today and it was very busy. There were queues of patients waiting to be seen. We've still got issues around staffing in A&E, and it's quite variable on a day-to-day basis. What we have done is we've now got a new senior leadership team in place there. It's been quite difficult to recruit to A&E at Hillingdon, but we've got a new clinical lead, and we've got a couple of new consultants and a new lead manager, clinical manager, who are starting in May. So we've done some work with our improvement team. We're waiting for that team to start to give them the opportunity to really shape what's happening. They've set themselves an improvement trajectory. They've had a bit of pushback from me about I don't think the improvement trajectory is quite ambitious enough. But actually, in a way, I'd rather they set an improvement trajectory that they felt they could really deliver and they can develop pride in that than that we set them an unrealistic trajectory and they always fail. So that feels more positive in terms of them taking the leadership on that, and we will absolutely support them in that. We do have an improvement team in the organisation. We have a programme called Cares Plus, which has rather gone on the back burner during COVID, but we're really starting to get people involved in that, and it's a quality improvement programme that allows you to take small steps in improvement and continually measure your improvement. So I think that will improve. I don't know if does that answer your question?
It sort of does, and I appreciate that you don't want to be strict on times and deadlines, which in a way is more honest than others that come in there and say, yeah, within 6 months it will be done and it will be fixed. My only follow-up question really is the problems that exist at Hillingdon Hospital. How much of that would you say is down to the building and the sort of fabric of the site? How much of it is down to the management over now and over the previous years, and how much of it is down to sort of poor staffing?
I think and others on the call might disagree with me here, but I think a lot of the emphasis on the perception of poor quality care has been targeted at the buildings, and there is absolutely no doubt that the restrictions on space and the way services are organised, Abbas said this earlier on, we have services that are not kind of connected to each other. There's a lot of transferring people around site. Is is part of the contributor. If you'd been talking to me before COVID, I'd have said that actually some of it, and not the leadership before me, but I think prior to that, I think there was perhaps a lack of emphasis on really tight governance processes and how you put that governance framework around what you do. And I think people had slightly lost sight of that, and not majorly, but I just think they had. I think there was a perception that things were better than they probably were, and the governance wasn't as strong as it could have been. I think what I would say now is that COVID actually has probably exacerbated the impact of the poor estate. So, you know, if you come to the hospital, we've got narrow corridors. It's really difficult to do social distancing. We've had to do ins and outs. It makes transit much more difficult. We're having to separate, you know, just even things like being able to segregate wards into patients with infection and patients not, and the fact that we don't really have enough single rooms. All of those sorts of things are actually make it much more difficult, and potentially make it more difficult in this next period of time, because we're not, even if we don't have another peak of the pandemic, we will definitely be managing infection control in a different way for the next period. So I think that has the potential to make it a bit more difficult for us to improve our quality, just because we're restricted by the facilities. And going back to your previous question about, you know, when do you think we'll see an improvement? We've got the outline of a new recovery plan, and at the moment what we're talking about is by September of this year that we would be able to answer an awful lot of the concerns that the CQC have, with a real focus on safety, and that we're targeting into 2022 to at least be back to requires improvement, but if we can get to good overall, that's our hope.
No, thank you. I think.
Thank you, Chairman.
Thank you, Simon. And you know, Simon made some very good points there. I think in the past it's been a combination of, I don't know, denial or not being on top of processes enough or understanding enough to understand what's going on. And we feel like, yes, in the past it's sort of things have been bad, and there's been denial, and there's been promises of improvement. It's not happened. And but what I will definitely say is that you know, in terms of the current engagement with yourself and others in your team, actually, I think I've noticed a sort of step change in terms of how things are being approached, and more honesty and openness about exactly what needs to be done. I mean, we all recognise that you don't just go like that and change, you know, a big ship that is like a hospital and change it like that tomorrow. So we're not asking for false promises, but I think, and also it's an iterative process with bits and on top of other bits over here and over here. So you know, from my personal perspective, I'm an optimist, natural optimist, and I'm looking forward to next year, maybe when we have this sort of overarching session again, and you know, hearing more about how the changes have been embedded and maybe how the culture is becoming more positive and stuff. That's my hope as well. But anyway, so does anybody else have any more questions before I wrap up the meeting? No, everyone's shaking their head. It's been quite a long meeting, so I apologise for that, but it's been a very good meeting. We've discussed lots of important things. Thank you, Patricia and Jason and everybody else from the NHS Hillingdon who've come along and stayed all night with us. So there's one more agenda item, which is obviously the work programme, but we can deal with that tomorrow, can't we, Nikki? We don't want to talk about that now, do we? I know I'm the chairman, but...
Chairman, I can literally just go through it very quickly.
Okay, go through it quickly. By the way, everybody else from NHS Hillingdon, please do leave now, because you won't be so interested in this. But thanks very much for coming and speaking to us tonight.
Thank you very much. Bye-bye.
Thanks. So, Nikki.
Okay, so Chairman, we have one more meeting during this municipal year, which will be tomorrow, which will be to receive updates from the different trusts, not including Hillingdon Hospital. So all the other trusts will be coming along tomorrow. The only other thing I wanted to mention was that I have started engaging with potential witnesses for the June meeting, which will be about children's dentistry, dental services. And that's it. Thank you, Chairman.
Thank you. And if there are any other questions about it, we can cover them tomorrow. But I know the discussion we had last time, things are being looked into, such as your ideas, Stuart, about the environment and rivers and stuff. So if there are any more questions about that, we can cover those tomorrow. Because I feel like everyone's worked very hard this evening. So so anyway, so if everybody's content, I'm happy to draw this meeting to a close.
Okay, can I ask that everybody remain on silent whilst I end the recording? Okay, Chairman,